Next paper is by Dr. Ravi Ranjan. Repeat DCR. Small change can lead to big results.
Good afternoon, judges and delegates. My topic is Repeat DCR Small changes can lead to big results. This is a small class physics technique. Job IAOC and basic relationship to DCR. As published in various journals, success rate of external DCR is 85 to 97%. In spite of excellent success rate, there are large number of cases with failure typically due to these causes. The aim of this study is to assess the success rate of repeat DCR by a small changes in surgical steps, and this is a prospective, uncontrolled interventional study consisting of 134 patients of LDCR from March 2011 to December 2020. And all these surgeries were done by a single surgeon to minimize the outcome bias of the surgical experience. And the incision were made on previous surgical scar, and intervening fibrous tissues were excised, and roughly 1 to 2 mm of the lacrimal sac around common canaliculi was saved, because it is always difficult to get sufficient flaps for mucosal anastomosis in repeat surgery, so that the sac remains as a disc with punctum nuts medial, similar to a funnel. And here A is sac remains, and the B is tip of the Bowman's probe coming out of common canaliculi, just showing a landmark. A 10 mm Arugaz bone trephine was used to make ostium in the nasal bone and nasal mucosa, so that the remaining entire part of the sac was sutured with subcutaneous tissue and periosteum of the medial side. And on 5th postoperative day, syringing of 1 ml of 0.4 milligram per ml of mitomycin C is syringed in newly formed passage, and these all cases were followed up for 1 year. And this is nasal endoscope after 1 year. Videos. Yeah, this is nasal ostium. Yeah, these all cases were followed up. These all followed up on 5th day, 1 month, 3 months, 6 months, and 1 year. And at each visit, the surgical outcome was assessed anatomically and functionally. Anatomical success was defined as patency of the newly formed passage on syringing, and functional success was defined as tearing assessment using Muck score. And epiphora of grade 0 on 1 was considered as success. And please come. For comparison of this study with previously published study, a meta-analysis were performed using MedCalc software. And since performing meta-analysis is not the primary objective of this study, that's why I am skipping the statistical data. And this is the tabular representation of comparison of my study with other studies. And one thing I want to highlight, the p-value for this study is less than 0.001, that is significant. Result of 134% over 10 years, 131% were successful at the end of mean follow-up period, that is 12 months, and 2% complained of epiphora of grade 2 or more, and a sticky eye despite successful syringing and patent newly formed passage, or 1% failed in syringing. And anatomical success rate is 133, that is 99.2%, and functional success rate is 97.7%, that is 131%. And personal communication with many ophthalmologists revealed that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. And as a result, DCR is ignored by many eye surgeons, and lacrimal surgery is increasingly being undertaken by ENT surgeons now. And in an era where other specialties are always looking to widen their surgical spectrum, we are losing our domain by ignoring this. And that's why we conceptualize this method to overcome the problem and make the repeat surgery easy to perform with successful result with short learning curve. And changes we made use of Arugaz bone trephine, and approximately 1 mm to 2 mm of the lacrimal sac was saved around the common internal opening, and 1 ml of 0.4 milligram of mitomycin syringing in newly formed passage on 5th post-operative day. And because the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram and 0.4 milligram, that's I use here 0.4 milligram mitomycin. And we used 1 ml of 0.4 milligram per ml of mitomycin syringing on 5th postoperative day, so that the antibiotic property of mitomycin is utilized maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which start from 4 to 5 days of tissue injury. On conclusion, the success rate of this study is significantly better than previously published reports despite large sample size, and we conclude and recommend this method because this method is easy to perform with reliable and comparative results, needs no costly instruments, can be used for mass surgeries, camps too. And certainly my operation is not for them, but it is a boon for the masses. This is my references. Thanks to, especially thanks to Mohammad Javed Ali from LBP, Dr. Dhiren and ENT surgeon, and Dr. Mr. Lokesh, my esthetician. Thank you.
Yeah, go ahead.
On good.
Actually, I am doing it in repeat surgery, and it is for adult. Yeah.
The mitomycin C that you used was used only for syringing at that on the 5th day for
Yeah.
one.
Yeah.
And was it a fixed amount in terms of ml that was
1
injected?
ml.
1 ml.
1
And
ml.
so my question is, if 1 ml of mitomycin C is irrigated through the ostium, most of it would drain into the nose and the mouth.
Actually, this is already studied by ENT surgeons. A very long study by some Mr. Dr. Lakhandeep, or some, you will get it. This is not harmful at all.
You know, it is not harmful. In fact, we have studied at different concentrations. So we've taken nasal fibroblasts and put it, in fact, Dr. Javed Ali is a co-author of that paper, where nasal fibroblasts were cultured and my mitomycin C at 0.1, 0.2, 0.3, 0.4, 4 concentrations for 1 minute, 2 minute, 3 minute, 4 minutes were seen and then observed, were placed for different durations and then taken out and seen. And the anti-fibrotic property was most effective, like you said, at 0.4 milligram, but for 2 minutes. Anything less than 2 minutes doesn't inhibit inflammation or fibrosis.
If you are syringing now, it will just for 5 minutes and more.
Correct. So anything above 4 minutes induces apoptosis and cell necrosis. And anything less than 2 minutes doesn't inhibit fibrosis.
In my study, because I have done it endoscopy and everything, there was nothing like that.
Right. And would you recommend this technique of using the bone punch for primary cases also?
Yeah, I have done more than 3,000 cases now.
So
I am doing it for 2002.
So in a primary case where you've taken out the bone punch, the bone through the punch or through that the arugas
Refined.
Yeah.
in repeat case, how do you still find the bone, or is there new bone that you remove it?
Most of the cases cartilaginous bones.
Okay, it's fiber scar tissue.
Yeah.
So, but in case you may not need arugas.
Nowadays, I am doing with every cases where it is new or repeat surgery, sir. Because it is that much easy, it will take only 30 to 35 minutes.
Just one question apart from the topic. So since you've been doing so many lacrimal surgeries, you just mentioned 3,000 cases. So in your series of failed DCRs, do you think the failure is because of a poorly performed prior surgery, or is it because the surgery has been done well, but it is mainly fibrosis which has caused the failure?
In my cases, it is most commonly due to selection of wrong site.
So in short, it's like a poorly performed prior surgery and a little bit of the sac mucosa is there to salvage.
Whatever I do in nowadays, most are the referred from other doctors, not mine cases. Mine cases has only 1 or 2% as yet. About 2,700 cases I have studied, only 36 cases.
Yeah, so they always say that if your failed DCR comes to yourself, it's always more difficult to treat than treating someone else.
Okay.